Good afternoon and half a day. The Committee on General Government Operation, Appropriation, Housing is now called to order. For the record, today is Thursday, May 20th. The time now is 2:04. Notice for this budget hearing was disseminated via email to all senators and all main media broadcasting outlets. First public notice was issued on Monday, May 10th. Second notice was Thursday, May 13th, and Monday, May 17th. Today is Monday, 20th. The committee will hear and accept testimonies on Bill 55-36 COR, the fiscal year 2021-2022 Appropriation Act, as requested by the Governor relative to the Guam Memorial Hospital Authority fiscal year 2022 budget request. I'd like to acknowledge my colleagues that have joined us this afternoon. We'll begin with the Oversight Chair on Health, Speaker Therese Terlahi, my Vice Chair, Senator Amanda Shelton. We have Senator Chris Drainus, who was one of the early birds, Senator Moylan, Senator Tony Ada, and Senator Telo Taidewi. The rules of this budget hearing shall be as those testifying on behalf of Bill number 55-36 CR relative to Guam Memorial Hospital Authority are invited, and they are invited to the panel. We have Ms. Lillian Posadas, we have William Kando, Yuka Hetsanova, and Annie Verdalio. Okay, we're on track. Written testimony shall be submitted to the committee. Please provide my legislative staff with written testimony for photocopying. Testimony may be read, and lengthy testimony should be summarized to about 5 minutes. You have more than 5 minutes, Ms. Posadas. You have the whole afternoon, hopefully not until the night, but earlier than that. Those testifying will be allowed to present oral testimony. Once you're done, please remain in the room for questions or for additional testimony as may be desired by the members of the committee. Question and testimony shall be confined to the substance or nature of the agenda. Personal inference as to the character or the motive of any senator or any individual testifying is not permitted. Any violation of this general rule of conduct will result in removal from the budget hearing room. Proper form and decorum shall be practiced by all present in the public hearing room for these proceedings. Individuals who fail to maintain proper form and decorum may be restricted from providing oral testimony and or may be asked, or actually will be escorted from the room. When you speak, please make sure the microphone is on and that you speak into the microphone. And please state your name and your title for the record. At this time, I ask the panel members from the Guam Memorial Hospital Authority to rise and for our Sergeant at Arms to please swear you in.
Okay, please kindly raise your right hand. Okay. Under penalty of perjury, do you all affirm that any and all information that you provide today, whether it be verbally, electronically, and in writing, be the truth, the whole truth, and nothing but the truth, so help you God? Mr. Chair, you're under oath. You may proceed.
Thank you. Please have a seat. Ms. Posadas, we will now begin to discuss your budget for the Guam Memorial Hospital Authority. I understand you do have slides. Do you have anything you want to present before you start the slides? Any statements you want to make?
I do,
Please.
Senator, if it's okay. I
Yes.
just wanted to take this opportunity to say thank you on behalf of the Board of Trustees, of management, medical staff, and employees of the hospital. We extend our gratitude for giving us this opportunity to defend and secure our hospital's fiscal year 2022 budget. I know you introduced some of our executive here, but there are other executive members who are running the hospital right now, and that's Dr. Jolene Ogun, who is the Assistant Associate Administrator of Medical Services, also Associate Administrator of Clinical Services. We have also Mr. Don Rabinow. He's outside. He is our Assistant Administrator of Administrative Services. Danielle Banglonia, she is our Compliance Administrator. Bel Rada, who is our Assistant Administrator of Professional Services. Ms. Christine Tucaro, she is the Deputy Assistant Administrator of Nursing Services, but she is now acting nursing administrator. And I just want to take a few seconds to honorably mention Ms. Gemma Beth Zimbillo, who was our nursing director, and she passed away this year in March. And so we lost a very critical member, very valuable, but unfortunately, we lost her. And so I'd like to start off our budget presentation by setting the landscape in terms of where we were from a year ago when we presented our fiscal year 2021 budget, where we stand now, our current situation, and where we're headed to for the next year, given our proposed fiscal year 2022 budgetary needs. And it's needs, not wants, it's just needs to keep the hospital efficiently and fully operational. So highlights of where we were a year ago, pre-COVID, we rolled it out, the budget from October 2019 to February 2020, with a budget of $137.9 million. March 2020, COVID arrived at our doors. And so with that, we had to immediately and quickly revamp our ER processing. We set up staging areas outside of the ER. We installed barriers in the emergency room. We discontinued the use of the hallway beds. We suspended urgent care clinic services and converted the urgent care into a 4-bed COVID care unit 1. That was our first COVID care unit. We simultaneously moved the skilled nursing unit residents out of the skilled nursing facility in Barragata Heights and converted it, and we moved them to the 3rd floor medical surgical annex. But in order to move those residents, we had to downsize the census dramatically from 28 patients to 14 patients, which meant we had to quickly find alternate placements or discharge half of the residents. We then opened up the SNF at Barragata Heights as the Islands COVID Isolation Facility. We called it the SIF. The SIF had a 54-bed capacity, but due to limited equipment and staffing, we could only use the 16-bed C-wing for the COVID patients who still needed to be accommodated and treated in a hospital environment. As the COVID census continued to pick up, we moved the second floor specialty services unit to the 1st floor admin annex and transformed that 2nd floor specialty services into a 4-bed ICU COVID care unit 2. We also then relocated the 4th floor pediatric intensive care unit to the surgical floor and converted that unit to a COVID care 3 unit. We converted the 3rd floor medical telemetry unit into a complete COVID care 4 unit. We also divided and segregated the 14-bed ICU into 2 sections, half for COVID ICU patients, the other half for non-COVID ICU patients. Then eventually, as the number of critically ill COVID patients continued to increase, we converted that entire 14-bed ICU into just completely COVID ICU, special care 5 specialty unit. Because we still needed to accommodate non-COVID ICU patients, we transformed the post-anesthesia care unit, which is our recovery unit, into a non-COVID ICU bay unit. We again had to move and relocate the SNU residents to an off-site facility so as to ensure we minimize their exposure given their high risk to COVID. So we immediately collaborated with the Catholic Social Service, DPW, GPA, Guam Water Works, and the National Guard and moved them over to the Catholic Social Services daycare facility. That was a very limited space, but that was our only option to quickly move those skilled nursing units out of the acute care facility into Mooning. All in all, we converted and restructured over 100 acute care beds into COVID care beds. At the same time, we maintained beds for the maternal child health population and the non-COVID patients. We also had to accommodate dialysis patients who really did not need to be hospitalized, but because the outpatient dialysis centers were not quite equipped or ready to provide dialysis treatment for COVID patients, these patients ended up needing to be in the hospital, so we accommodated those patients. As the numbers continued to remain high, as well as non-COVID patients needing acute care, we moved and we split the 1st floor rehab department. We moved up the outpatient part over to the SNF, and we kept the inpatient rehab in the gift shop. that was we had no choice, and I know the volunteers ladies weren't too happy with that decision, but again, because of our limited, space, we had to use whatever space was available. And so we converted that gift shop into an inpatient rehabilitation unit. In December, when we received our first allotment of vaccines from Public Health, we rolled out our employee vaccination clinic, as well as vaccination of non-GMH employees who met the elderly population criteria. So from that vaccination clinic, we vaccinated 214 elderly, 1,180 GMH employees, and 2,154 non-GMH individuals from the community. Where we are right now, the highlights is that we've moved those SNU residents out of the Catholic Social Services back to the Barragata Heights skilled nursing facility. We're only occupying the A wing for now because the facility, we are beginning to work with do an A&E for that facility to become the alternate care facility if in the event we have another pandemic. And so we were approved by the FEMA grant funding $15 million to convert that facility into a switch-ready alternate care facility. So that's what we're also doing with that facility. The pediatrics PICU unit is now back to their 4th floor, original location, and all other acute care units such as the medical telemetry, medical surgical, and surgical are back to their original settings with the maximum bed capacity, and we've enhanced and expanded the cardiac telemetry capability and also our isolation and negative air pressure. We now have 113 cardiac telemetry beds, where we used to only have 26 in the 3rd floor. We've really increased that capacity. We also have increased our negative air pressure beds and our certified isolation rooms. And Mr. Kandu can probably give you more details on that one. We rolled out the vaccination of the DOC inmates and officers at the DOC on-site clinic in Manila and in Hagåtña. Out of the 550 inmates, we vaccinated 285. We will continue to vaccinate them in the upcoming weeks. We completed the OPA audit in April, which is earlier than compared to previous year. And next year, we're targeting to complete that even earlier in February. The audit, however, revealed a $10 million loss in revenues, and that was substantiated because of the suspension of elective surgeries, decreased patient census. At the same time, we suspended outpatient clinic services. So that contributed to our lost revenues. What our vision is for the next fiscal year is that we will regain national accreditation. And so we do have an A team working on it already. We've established a roadmap how to get that accomplished, but we do need to have ongoing, intense, robust education and training to get everybody on the same page towards accreditation. Our goal is also to maintain CMS certification, and so, so that we can continue receiving Medicare and Medicaid funding. And I just want to note that we're also kind of concerned that come the end of September 30, if the Medicaid FMAP percentage goes back to the 55-45, that's going to really have a significant impact on our Medicaid reimbursement. So I hope that you're all paying attention to that situation, and maybe, hopefully, we can find a way to collectively make sure that that doesn't happen, that we can retain the current FMAP at 89%, because that really is very helpful. Our third goal, as far as our vision for the next fiscal year, is that we will launch the new electronic health record system. The target date for that is October of this year, 2021. And a lot of training is going on right now with that goal. We also want to solidify our financial posture by enhancing and improving our billing, collections, and revenue processing system. I'll let Yuka speak a little bit more detail with that one as far as the revenue cycle management contract that we're going to be engaged with soon. We are also securing a clean scrubber billing software that will help us get our bills and our claims cleaner and quicker. And we want to add and expand outpatient clinic services. This will increase revenue-generating opportunities for the hospital. Another goal of our vision for the next fiscal year is to taper our dependence, our reliance on off-island staffing solution resources, such as the travel nurses and the global locum tenens doctors. Please don't get me wrong, these travel nurses are great. They really came in and they continue to help us very much with our situation at the hospital. It's just that it is quite costly. And so we're trying to see how we can decrease that cost. With accreditation, we can pursue bringing medical students on board for their residency and perhaps expand our options to recruit physicians, especially those who are from Guam, who have gone off island to get their medical degree. We want to bring them home. We want to bring that talent back to the island. And then lastly, we are looking to explore the hospital's eligibility as a qualifying employer for the public service loan forgiveness. This is where medical students, especially those from Guam, who get all these loans to get their education, they can rack up about $200,000 or $300,000 in loan, and we want to help them get that loan forgiven. But then they come and work for Guam Memorial Hospital or any of the facilities here in Guam. Some of the accomplishments I just kind of want to highlight that we've reduced the on-call and the callback pay. That's a significant, expense that we were able to reduce. We also have the AmeriCorps Serve Guam folks with us. That's a grant, a federal grant. They help us in terms of individuals who come into the hospital as self-pay. They help those individuals fill out the form so that they can then get Medicaid or MIP. Instead of just handing them the form, those individuals help them go through the form and fill it out, and then it gets followed through at public health so that they can get Medicaid or MIP coverage. We recently received the 2 Healthcare Asia Awards for Hospital of the Year and COVID-19 Response Initiatives of the Year. That's really a very significant and very meaningful award for the employees at the hospital. It just, again, gives that assurance and the confidence that, if we can do COVID care, we can pretty much do anything, and we continue to give that care to the people of Guam. So it was a very rewarding recognition for our employees at the hospital. From this pandemic, we've established and really strengthened our partnerships and relationships with the DoD, the Army Corps of Engineers, the HHS, the FEMA, and the Joint Regional Marianas with Admiral Minoni. We've just really solidified and heightened and increased, strengthened that relationship with the military, with our military partners in terms of helping us continue the services at the Guam Memorial Hospital. So I'm going to end here, and I'm going to have Yuka, our CFO, present the PowerPoint in terms of the budget. Thank you.
Thank you, Ms. Posadas. Yuko? Just state your name, your title, and then go for it.
Good afternoon, Senators. Thank you for having us here today. My name is Yuka Hechanova. I am the Chief Financial Officer at the Guam Memorial Hospital. I'll be going over the PowerPoint slides. I believe you all have a copy, and they're going to also project it onto the screen. There we go. Okay, so next slide. So this slide just shows the divisions of GMH that are actually involved in the direct patient care and the departments that are under them. We have several departments and 4 divisions that are handling direct patient care. Next slide. The next slide shows the divisions, the 3 divisions of administration, operations, and fiscal divisions that are involved in indirect support for indirect patient care. Next slide. So this slide just is an overview, a very quick snapshot of our projected operating expenses for FY 2022, which is $140.8 million. And this is really what we need. So all the departments submit their budget requests to our budget office, and we, of course, scrub it and pare it down as much as we can. And this is really the lowest that we could get it to be. So in meeting these operating expenses, we had projected operating revenues of $110.3 million, which is a bit aggressive, but we do have a lot of optimistic outcomes that we see for FY 2022. We did, as Lillian mentioned, we have a revenue cycle management consultant coming on board. We just finally got the contract signed and the notice to proceed just this week, so we can get started on that. We've been waiting almost 2 years for this project to get going, so we're very excited that we're going to see a lot of improvements in our revenue cycle. And we also hope that in 2022 that the operations at the hospital get back to pre-COVID normalcy, where we'll have more people coming back to the hospital. We're not really seeing the census increase like in the emergency room right now, but hopefully by 2022, things will have normalized enough for us to meet these operating revenues. The projection also includes the governor's budget from the pharmaceutical fund for us for $18.3 million. And we also estimated $9.6 million in federal grants that we'll pursue through the Department of Interior, Health and Human Services, and from FEMA. Next slide, please. So the next slide shows just a breakdown by the divisions of the budget. And so when I mentioned earlier about those divisions that are under direct patient care, those divisions actually encompass about 76% of the budget, while the indirect patient care divisions encompass 24%. So 3/4 of the budget does go to direct patient care. Next slide, please. The next slide. This one is the FY 2020 payer mix. So this brings into perspective our mix of patients and how we get funding for their care. So the 3 M's are 57%. The 3 M's are Medicaid, Medicare, and MIP that we call them the 3 M's. And this allocation is based on gross revenues in FY 2020, of which these are audited numbers of $177.7 million. So this payer mix is actually pretty consistent with prior years. It's almost always the same every year. But I did want you to focus your attention on the slice that says self-pay. This is the patients that have no insurance, and this is $25 million of gross revenues that we have from self-pay patients. In FY 2020, we collected only $5.4 million, so we really collect about 20 to 25% of this self-pay population. But as Lillian mentioned, one of our initiatives is really to move patients from this self-pay area and get them public assistance if they qualify. Next slide, please. So this is just a snapshot of the patient census over the last 10 years. And it really is meant to signify the decline in census we had in FY 2020 because of COVID. So we went from, in 2019, of 36,000 patients to 29,300 in 2020 because of COVID. So of course the line dips in also 2016, and that is when GRMC opened, so some patients also went there. But in 2020, we really did lose a lot of patients because of COVID. They just were not coming to the hospital. We shut down for a period of time. We stopped a lot of outpatient services. And so this really impacted our financial standing in FY 2020. Below the graph there is also some statistics to also indicate the decline in inpatient days, how our outpatient visits had also declined, and urgent care as well. Next slide, please. This slide is really, without going into so many numbers and details, it illustrates what happened in FY 2020, particularly in April when we really shut down. The solid line there is actually the outpatient census for FY 2020, while the solid line below it is the inpatient census, which did not change too much from FY 2019, but the outpatient census just dipped in April, and it has not come back up to the level that we experienced the prior year. And then right below that is just a synopsis of some of the billings that we did. In FY 2020, we really did actually bill a lot. We're pretty aggressive in billing. Part of it was because COVID had slowed the hospital down, it really allowed us to focus on catching up on billings and getting all the coding done. So in a way, it helped us get caught up on a lot of work. So because of that, we were also able to collect $104.4 million, which was a pretty stellar year. So as of April 30th of this year, we're still a little behind on collections. We're having some issues with billing, things that we're working on right now. And we're hoping that the new electronic health record system and the other peripheral programs and softwares that are going to come with it are going to really enhance our billing and improve it anyway. Next slide, please. So some of the initiatives that I want to mention that we're doing to really get to the goal of achieving financial stability. It's a strategic goal that we have. And so as I mentioned earlier, our revenue cycle management consulting services are finally going to start. We really had a setback of almost 2 years in getting this started. And one of the first things that we want the consultant to do is to look at our charges and to right-size them and make them a lot more streamlined. We could even bundle a few of the charges and make it easier to bill. But mainly, it's really to restructure our revenue cycle management, get our processes in line, get them more efficient so we can get cleaner bills out, reduce our receivables, and that means we'll get faster payment. Another thing we're going to do, or we've already started, was the procurement process for getting a bill scrubbing software. This is where we would upload bills before they actually go out, and the software, in a matter of seconds, will analyze it and see what are the areas that we need to fix before they go out. Cleaner claims means we get paid faster. We also continue collaboration with the Department of Revenue and Taxation on tax garnishments for those collections that those that are on payment arrangements that are not making their payments. We also get assistance from the Office of the Attorney General. This has been going on for a couple of years now for small claims court for patients that renege on their payment arrangements. One thing I'm really proud of is really this year we've started to engage a self-pay task force, which is comprised of our patient registration, social workers, and case management, where instead of before we would just give the application to self-pay patients for public assistance, now they're actually following through and doing a lot more to make sure that these self-pay patients can be covered by public assistance through Medicaid or MIP. We're also actively training our revenue cycle staff. We have a grant of over $200,000 we got from the Department of Interior. So we're trying to get these staff certified and trained. We have about 90% of the billing staff right now is certified because of the grant. And we're also continuing to strengthen our relationships with our insurance companies. We're working with Take Care right now on a reconciliation of a lot of past accounts that are disputed, and we hope to get that cleared up within the next month or two. They have engaged actually a third-party firm to pretty much audit and review those past claims so we can come to an agreement. Next slide, please. This is an overview of the CARES funding that we have received. From the Provider Relief Fund from the Health and Human Services, we received direct cash support of $9.7 million. The last of that, the $1.9 million, we just received in January, but the rest of it we did receive in FY20. We spent this money on a number of COVID initiatives. We bought beds, we bought respiratory items and equipment. We bought infusion pumps. We renovated a number of rooms and created care units. We had to buy equipment for all of that. We bought lab analyzers, radiology equipment. We bought an X-ray machine. We have an EKG and ultrasound. We used some of this money to set up the skilled nursing facility as the isolation facility back in April and March. We bought HEPA filters. We upgraded connectivity also to the skilled nursing facility because now we were using that for COVID patients. We bought a lot of PPEs, gowns, masks, gloves. There were several interruptions in the supply chain, so costs really went up. Some of the supplies were hard to find, and if you really wanted it, you had to pay the price for it. We also received $8.9 million from the Government of Guam Coronavirus Relief Fund. We were actually allocated 11.9, but due to some reallocations, we did not receive $3 million of it. So overall, we received 8.9. 900,000 of that was actually transferred to the Office of Homeland Security for them to procure some critical equipment for us. But most of this money was used to pay differential pay and to pay for COVID doctors that we hired specifically for COVID. So the amount to date that we've all spent on differential pay and the COVID doctors is actually around $10 million, so we still were not able to get the reimbursement for these costs, which leads to some of the losses that we experienced. Next slide, please. So our current financial posture, this is a snapshot of it as of April 2021. Our operating revenues are slightly lower than last year. Our gross revenues are actually relatively stable, but we've had to reduce the gross revenues by an allowance based on payment behaviors of all of our payer mix. Our non-operating revenues are going up because of the grants that we're finally starting to receive, but we still experience a net loss of $9.2 million as of April. As of 9/30, the audited amount is $10.2 million. So some of the expenses that are out of the ordinary that we've experienced is we've procured the travel nurses, but to date it's about $12 million we've spent on the travel nurses. $10 million of that is reimbursed by FEMA. We just got the FEMA money in April. So before the FEMA money finally came in, we had the nurses on board since late September, early October, and we did have to pay about $4 to $5 million up front. So while we were waiting for the FEMA money, we had already paid about $5 million for the nurses. We also had to spend a lot more, about $4 million extra from the prior year for supplies. A lot of the pharmaceuticals that we had to purchase that treat COVID patients, such as remdesivir, we spent about $2 million to purchase that drug. It's a very expensive drug that we needed to procure to treat the patients. We also had an increase in laundry services as PPEs were very difficult to procure. We resorted to using the cloth gowns because disposable gowns were just not available. We had them on order and just never receiving it. So our laundry service contract, those payments also went up significantly. Our cash as of April 30 is 2.3 compared to 8.3 the year before. Our audited number at 9/30 is 12.1 because we still had a significant amount of cash from our provider relief fund. Our payables have gone up because the cash is going down. Our payables right now are at about $17 million. Also, we're pursuing other grant opportunities. There is a COVID TAP grant that we're waiting on, about $2 million. That's from the Department of Interior that will also help cover the costs of payroll that we had for COVID. Next slide, please. And an update on our allotments. We are getting the allotments from DOA rather timely. So to date, we've received $14.6 million They usually pay us right before payday, so they come in at the right time. Our receivable from the Department of Corrections for the outpatient clinic is 1.7, so this goes back to about 2018 and 2017, which some of the bills they were not able to pay. Our inpatient clinical is at 3.9 million right now, and so for a total of 5.6 million, we still that DOC still owes us. So receivables in general, I also broke it down on the bottom of the slide there. So our gross receivables from the 3 M's, the insurance companies, and self-pay. And then the allowance. The allowance is where we have to adjust our gross receivables to something that is realizable. So based on the payment patterns of the different payers, we have to adjust it. So as an example, anything that's still sitting in the 360-day and over 1 year bucket, we fully allow for that. So although we may collect on it to follow the accounting policies and stuff, we fully allow for it so that our net receivable is at a realizable level. So the amount of the allowance can be rather high. So I'm going to turn it over to Mr. Kando now to go over some of the CIP items.
Good afternoon, Senators. My name is William Kando. I am the Associate Administrator of Operations for the Guam Hospital Authority. Just a quick update on our electronic health record implementation, which we signed the contract back in April of 2020. Basically, that means we rolled this contract out at the beginning, very near the beginning of COVID response. And that didn't sway us. We had no choice. We have to transition to a new EHR. The project kickoff was in May of 2020. We had to do this EHR rollout predominantly remotely through remote communications with our contractor, MedSphere. Enterprise assessment took place in September of 2020. Super user training and build took place in August of 2020. In March of this year, they actually came out for the first time in the middle of about the 3rd week of March of this year. That was the first time they came, and they were doing also super user training and building for us. And then integrated testing took place April and continues through June of this year. They'll be coming back out in July. This will be the second time that they'll actually be coming to Guam. So the end user training will be taking place July through September of 2021. The original go live prior to COVID was May of 2021. It's been adjusted to October of this year. Additional scope that we added to this project is a laboratory information system. The contract was signed in December of 2020, and the project was kicked off in January of this year. And then we also added wound care management. Contract was signed in February 2021. And the project was kicked off in March of 21 this year. Next slide, please. Capital infrastructure update. Recently completed projects during this most trying of times. Phase 1 implementation of our PIXIS system. This is our automated pharmaceutical machines throughout the hospital and also at our skilled nursing facility. Phase 1 was completed in September of 2019. Phase 2, 15 of 21 nursing units completed in 2020. And then Phase 3, radiology in the skilled nursing facility was completed in January and April of 2021. We modernized our hospital vertical elevators 1 and 2 in March and May of 2020. We repaired boiler number 2 in May of 2020. We did electrical and mechanical upgrades, collaborated with the Army Corps of Engineers to upgrade our care units 3 and 4 so that we could have more negative pressure rooms and also have the capability to do hemodialysis in many of those rooms as well. We installed and commissioned Ready kits. These are the patient telemetry monitoring, patient telemetry central monitoring systems throughout the hospital that Lillian was mentioning earlier. We completed 4 nursing units in September through December of 2020. And then in the ED, in our critical care units 1 and 2, and in 5, which is our ICU. So 4 more units completed in March through May of 2021. So that was a total of 6 ready kits, telemetry monitoring systems. They come in 20 monitors per kit. So basically, almost the whole hospital, with the exception of maybe the MCH area, is wired for central monitoring, because we just were preparing for the worst and hoping for the best. We implemented our Rounder 2 telemedicine program, which was launched in February of 2021, which gave GMHA 2 avenues to provide critical care telemedicine, and both Innovator Health Physicians Group, and we also contracted our independent MDs, which were actually the DoD physicians that had been assigned to us near the beginning of the response. We brought them on as independent physicians later on. Our Communication Center relocation project was completed in March of 2021. We just recently completed Cura 2, which is our ICU overflow unit, which has a capacity of 4. We did an electrical upgrade. We contracted that out, completed it in May. That gives us more ability to do hemodialysis in that unit as the ICU overflow. I'm not going to mention all these purchases because Yuka was just going through all of them, all these various fixtures, furnishings, and equipment purchases during COVID. Next slide, please. CIPs in progress or in the pipeline. The main electrical distribution panel and sub-panels, we continue to maintain the main electrical panel. Instead of replace it, we're maintaining it, collaborating with GPA. GPA has been assessing it the last 2 years, and now they came in and recently assessed it again this year, so they're assessing it once a year. They assess it, tell us which parts we need to buy. We buy the parts, and they're getting ready to install. So come next week will be another installation where they're replacing either breakers or some kind of switching devices, whatever they need to replace on this system, they're replacing it. So that's a good collaboration. We're doing HVAC system upgrades. This is a major. All of these are part of the Army Corps of Engineers assessment. These were identified by the Army Corps. So these are the projects that we're hitting. Hospital-wide, we're targeting replacement of air handling units. We've only replaced 2 out of 64, but we're expecting bid submissions towards the end of this month for a package of 15 air handling units. So these are one-to-one replacements. So sometimes we're doing packages that are easier to do because they're one-to-one replacements. They don't require a design. Other HVAC upgrades is more complex. We had to do a design, for example, of our OR. We've completed a design of our HVAC upgrade for our OR. We're working on one for our radiology department. We're nearly complete with designing for the ED and our ICU as well. So once these designs are complete, then we're in a position to proceed with the construction phase. For the OR, we're just pending an authorization to proceed with funding from DOI that's already been earmarked by the Office of the Governor, $3.5 million. That's more than we need for the OR. It's a lower estimate than that. So whatever we have as a balance, then we'll apply it to other possibly one-to-one replacements of air handling units. We're currently in the price negotiation of an A&E design phase for the hospital roof and envelope upgrade. So right now we're working with the most qualified offer to try to establish a good price on that project, and then we'll be able to roll out the design so that we can fix the roof and also the envelope in phases. We have the Z-Wing design going on, which involves, they've already completed the abatement phase of that design. So we're trying to do an RFQ procurement so we can do the abatement to remove any kind of hazardous paint, asbestos under flooring, tiles. We're trying to proceed with that phase of this project. Then they're going to be also designing for a combination, looks like a combination salvage and demolition of the Z-Wing, followed by possibly development of additional parking. So we're still bringing, we have 3 options that we've been working with the Board of Trustees. We're bringing these options back to the full board this month so that they can give us a final approval on the best approach based on those 3 options. We've been doing information technology upgrades throughout COVID, and these continue also in alignment with our EHR rollout. We just procured 2 C-arm systems, one for our radiology IR, this is interventional radiology, and one for our OR. We need to be completed with this project by the end of June of this year, and so that's going well. We completed, we'll be completing our repair to boiler number 1 in September of this year. We are in the review process of an IFB for the radiology angio suite as well. This is a much larger project, so this is going to go through a more complex IFB review process involving the AG's office. And we're looking at replacing our fleet, our vehicles, and then we continue to buy, even though we've bought quite a bit of medical equipment during COVID, we still have more to do. And so, especially in, we're planning to maintain this GMH for the next 5 to 7 years, so there's going to be ongoing medical equipment purchases. Just on the last slide, just a planning and development update. As you know, we've been engaged as a Team Guam task force established by the governor to build the new GMHA facility. Actually, a medical campus pulling together the 3 agencies, GMH, Public Health, and Behavioral Health. So we've been engaging in Zoom meetings. These task force, one for medical services, one for land and infrastructure, and one for finance. And so next after that would be the design concept development, as well as very complex assessments as well, to include environmental, archaeological, and explosives, followed by A&E design phase, and then we're looking forward to a construction phase. As Lillian, our hospital administrator, mentioned, we're also very excited about our alternate care facility project, $15 million, 100% federally funded, to develop a medical pandemic isolation facility. A big part of this is an HVAC upgrade, and so this is already in the design phase. We're already getting ready to receive bid submissions for 2 brand new chillers, about 130 ton each. This is equipment purchase only, so that we can proceed quicker. And then as those are selected, then our designer would also be able to design for the connection and how those are going to be properly connected to the facility while they're being manufactured. So some of the other scope is very impressive, where each of the rooms throughout the facility, 54 rooms, in total, they would all be negative pressure capable. We would even develop a CT scanner room. We're looking at 6 ICU beds in these, and then we get to purchase brand new beds, acute care beds for the entire facility as well. And so just a lot of exciting things and other medical equipment to go along with it, so that it will be a switch-ready a medical pandemic isolation facility. If we ever, hopefully we never have to go through this again in our lifetime, but if we do, we'll be in a much better position to respond. Even better than the way we have, and I think we've responded pretty well. And then next steps going forward, of course, as I mentioned, A&E design, and then a construction phase for this alternate care facility. That's the end of our presentation. If you have any questions for us.
Ms. Posadas, does that complete the presentation on your budget? All right. Thank you. You know what, for your GMH folks, thank you. You folks have been busy. Obviously, great budget presentation. You guys have just been busy. I'm looking at your budget request, and now I'm just going to move along because we're going to take a look, and we'll figure out what we need to do to help you, to make sure you stay afloat and stay in progress. I want to keep all your folks busy and continue the great progress you guys are doing. But I'm going to go ahead and pass it on to the oversight chair, and then it'll be followed by my vice chair on the Senator Amanda. So, Speaker Terlai, do you have any questions to the panel?
Yes, thank you very much, Mr. Chair. And thank you to Lillian Posadas and Dr. Badalio, Yuka, and everyone at GMH. I know there's some outside as well, and all of those, as they said, who are still over there, that for your work throughout the pandemic, of course, but in your presentation today, the accomplishments that you've outlined, very impressive, especially the facilities upgrades. I want to commend you on that. I especially want to commend you on the award you received recently. 2 awards, I guess, Healthcare Asia Awards for COVID-19 response, noting GMH's significant achievements during the pandemic for implementing 40 protocols for the clinical and operational management of COVID-19, establishing a state-of-the-art telehealth, telemedicine, and physical Rounder 2 program to sustain life-saving intensive and critical patient care services, creating a war room committee dedicated to the individual clinical management of COVID-19 patients, creating a daily briefing document and daily COVID-19 huddles to ensure streamlined communication among all branches of the hospital, establishing electronic daily wellness checks to mitigate the spread of COVID-19 among GMHA staff and keep up with the crucial staffing levels. I know you were on the news with this, and that, but I wanted to just make sure that that is stated again here today, and to give you all our thanks. Mr. Kondo, I'm sorry, your name escaped me earlier, but thank you again. And so I would just want to so we were given a spreadsheet by OFB, Office of Finance and Budget here at the legislature, that shows the $140 million that you've laid out that you need to operate, Yuka. But I just want to make it clear so that you're only requesting really from the legislature an appropriation of $18 million out of the $140 million. Only 18 is what you are requesting the legislature appropriate from the pharmaceutical fund. And that all the rest of it, you're going to get $110,250,000 from your operating revenues. And this is a change from last year. Last year, the legislature appropriated about $28 million, about $10 million more than what's being asked for this year. And it looks like you're trying to make it up with the operating revenue, right? So because the operating expenses it used to be 137, now it's 140 million. So they're kind of the same, but you're going to make up more from your operating revenue side. And so I know you've laid out, the mechanics of how that will be possible, your increased, technology and other different approaches to making sure the revenue comes in. And so I want to commend you for that. I wanted to check because I guess OFB is going to make sure, but they had talked about a more conservative approach to the pharmaceutical fund, like their estimates, but I guess we'll have to make that adjustment if that's what they see in the end. But I guess I wanted to clarify Well, you've actually answered a lot of my questions in your presentation. If I could just give me 1 second so I don't have to repeat any that you've already answered. Oh, yes, and I especially want to commend you for the capital improvement projects. So you seem to have been able to update your capital infrastructure because none of that was requested last year. None is requested this year. You're not asking for legislative appropriation to fix the roof or do anything of that. And so I just wanted to make sure what the timeline might be for that, particularly the roof. And I know you outlaid that that's in the process of, I think being, if I could find it, the roof. If you could just remind me the status of the roof, and when do you expect that to be completed?
Yes, ma'am. So Senator, we'll be in the design phase for the next several months, but we won't wait till the design is fully. We're planning to do even the design in phases, so that as they start picking certain sections of the roof, like we're very heavily focused on fixing the laboratory roof, which is a much smaller section than the A and B wings of the hospital, just because our lab is there's sections of that roof that are really bad as far as rainfall, and so we're going to be doing the design in phases, and as soon as these designed phases are complete, we're going to be bidding it out each small phase, leading to larger phases, so that we're not waiting for the whole design to be complete. Okay. But we'll be designing this over the next several months.
All right, and then the construction, or then the bidding, and then the construction. Yes, I guess I'm just curious. It's been since 2019 that we tried to give the hospital $10 million at least for capital improvement projects from excess revenues. We found that there were excess revenues in that year, and again in FY20 that they just announced yesterday. And they used it to pay, what do you call that again? The deficit, right? But the money was not transferred to the hospital. And it seems like the hospital's not requesting it and that they're just going to spread these projects out. But I guess I remember the Army Corps' report, and that they reiterated that some of these projects that you're working on, but that they were pretty urgent, and I don't know what else to say except, we're just, I guess that you're confident that you're going to make these operating revenues, that you're not going to need anything in addition from the Government of Guam or the General Fund or from any other fund. And they had told us in the meeting that we had that you were going to be receiving additional federal funds directly to the hospital. Is that in this presentation?
We're estimating about $9 million that we can get from federal funds. I think during COVID, we really learned a lot about the opportunities for grants. We met a lot we worked with FEMA, with DOI, with HHS, and as we mentioned, the relationships with these federal partners became a lot stronger. We have better connections, so we're hopeful that we can get other grants. And even through the pandemic relief funds, they've been very generous to give money directly to the hospitals. So we hope that those kind of opportunities will be available. I did mention that the budget is really $140 million based on what we really need. So if we need to make it happen, we really have to be more aggressive with our grant funding and also with our billing and collections efforts as well.
All right, and you're confident that these projects that have been put on hold, the CIP projects that we've been talking about for years now, at least since I've been here, same projects, that those can wait for the schedule that you've created, I guess?
I think it's important to note that the projects that we completed during COVID in response to COVID and the funds that we have received from the coronavirus funding, federal funding, all of those were directly aligned with the Army Corps assessment. All of those projects, even the medical equipment, they called it out that we needed to replace medical equipment throughout the facility. So, like the ready kits, that the central monitoring, the telemetry system that was hospital-wide, that project, we were already planning to do it prior to COVID. If we had done it just normal, that would have been a phased project that we would have completed over 2 to 3 years. Instead, we completed it in like 9 months. So the silver lining for us for COVID was it kind of gave us a jump start on meeting completing these projects. So we have some wind behind our sails, and we want to continue with that momentum.
All right, and and at all the same time, you were able to also give some nurse differential pay. I want to commend you on that too. So you were able to find money to do all of that. But in addition to the $9 million that you're talking about, is there any in the more recent congressional relief funds, any directly designated for GMH?
I have not heard of anything that will come directly to the hospitals. So far, what I've heard is it's just going to the states and the territories right now.
Okay, that was something else I thought that we were told that during our meeting with the governor that the hospital would be getting some of its own direct funding from federal sources. But okay, all right, Madam Chair, I'm going to yield it back. Thank you.
Thank you very much, Speaker Terlahi. Sidus Masi to the panel today. Thank you to the team at GMH, everyone there for all the work that you've done throughout this pandemic the last year. I think as the speaker said, congratulations on the awards that you recently received. And I also like to commend you all on the implementation of the electronic health record system over this past year. I think that was a big concern for us in previous hearings in the 35th Guam legislature. So I'm glad to hear of your progress and the improvements that will come from that with revenue collections. Also, I was reviewing the GMHA website, and I want to commend you on that as well. It's beautifully redesigned and went over it, very easy to navigate with all of the highlights of your mission and all of the caring that you're doing at the hospital. Very impressive. So I know that lots of times GMH gets a bad rap and we hear in the news the negative things, but today I think all the hard work you've been doing all these years really shows itself. So congratulations to you. I think you've answered most of my questions in your very, very thorough presentation, but I wanted to talk a little bit more about the revenue collections and the assistance that you're getting from the Attorney General's office. If you can tell us, has there been an increase in what you've collected, and have you seen a stunt in that collection during the pandemic, an increase in default in payments from our patients?
We have. During the pandemic, we were even not pursuing any of those collections. As a matter of fact, it's very recent. I can't pinpoint the exact day, but in the last few months, we've started the discussions again with the AG's office and going back to small claims court. But we did have a considerable lull during the pandemic, yes.
Okay, thank you very much. And I know that the federal stimulus that our residents received, the EIP 1 and EIP 3, were eligible to be garnished for government debts. Did the hospital receive any significant revenue from those garnishments?
To my knowledge, it's only income tax refunds that are being garnished.
Okay. All right, thank you. Maybe I got that information mixed up, but I appreciate that. And you talked a little bit about the $15 million funding from FEMA that you already received. Is there a timeline, a deadline for us to use that money and finish the projects at SNF?
I don't believe there's a deadline set yet, but we're not gonna, we will collaborate with our representative from FEMA, Bryant Trang, on that. All I can tell you is that we got a really good head start on this project because it's already in the design phase, and we're even looking at, we've already designed a portion of it, the isolation of the B wing, which we had wanted to do in the heat of COVID to bring the residents back from Catholic Social Services and bring them back into a facility that could still do COVID, but isolate them, isolate the HVAC system. And so we're still, even that portion, even though it was not in the original grant, $15 million grant, we worked with FEMA, they approved it, and they said that it could be reimbursed at the closeout of the grant. And so even that, we're getting ready to bid out. So we have a very good head start, and we're not going to wait for any, we don't wait for any expiration dates. We're just going to try to do it as quickly as possible.
Okay, that's great to hear. So the plan for SNF will be that we'll still keep the patients at SNF in the future, and they will be isolated. That's how it's going to work.
That is the plan, but if we need to use the whole facility, it would be safer then to move them out of there and just make that whole facility as an isolation facility. But yes, we do intend to keep them there, and that's why we want to separate, the ventilation to protect them. But if it's safer to move them out, we're going to need to move them out.
Okay, and it'll remain what we did, the plan will be what we did this past time to move them into the facility. I forget where you said we moved the
Catholic
patients.
Social Services?
Yes.
No, we don't want to go back to that because it was really very, very small. There was no privacy for those residents, so we didn't think that, we want to use that again. We had to at the time. We had no choice. We had to use it. But, lessons learned, we will not put those residents back in that kind of a setting.
Okay.
So for their dignity and for respect, we have to find a better, another site.
Okay, so I'm sure that will all be factored into your future planning for contingency, where they will move if the isolation is not possible in SNF. Thank
Correct.
you very much. Okay, and I appreciated the breakdown of all the CARES Act money that you used. Is it safe to say that all the CARES Act money you received was already expended?
Yes, it's been expended.
Okay, thank you very much. All right, thank you again, GMH, from everyone from the maintenance team to the medical staff, the administration, Sidious Masi, for your service.
Thank you, Senator Amanda. I think I have to recognize our colleague that joined us. It's Senator Torres and Senator Brown. I'm correct. Senator Chris Reynolds, do you have any questions to the panel or any comments you want to make?
Sidious Masi, Mr. Chairman, and just a few comments and a couple of questions. Lillian, Dr. Berdalio, Yuka, Mr. Kando, and of course all your team out there. Nothing short of amazing what you've been able to do over the last 14 months, and congratulations on the awards that you've received. That really is, I know from from my favorite nurse personally that is something that really lifts the spirits at GMH, and so that's just amazing, and congratulations once again to your team. My only question is, once again, earlier we had public health here, and it looks as though their budget was adjusted in accordance with the anticipation of monies coming in under the American Rescue Plan. So once again, just to kind of reiterate what the speaker, the chair, was asking, so we see a total adjustment here of about $10.5 million down from the request. And so that, once again, Yuka, that's being realized through anticipated collections?
Yes, our goal is actually to really reduce our reliance on GovGuam appropriations and be more autonomous. That will never completely go away just because of the population that we serve, but we really are optimistic that improving the collections and the whole revenue cycle process will definitely bring some relief to the hospital as far as cash is concerned.
Okay, yeah, so we just want that on the record because of the fact that, much like earlier, so, you know, that has a great impact in terms of how we're anticipating the use of those funds. So this is, so thank you for the clarification. I guess the only other thing then is, William, so everything on the CIPs that are noted on the CIPs in progress, you anticipate all of those as they go forward, that they would be funded under your current budget request?
They're going to be funded with various sources of funding. Some of them are federal, some of it maybe general fund, operational funds. Sometimes I go to Yuka's office and I talk to her very nicely, and she helps. She helps.
That's a good idea, by the way. That's a really good idea. That's good, Bill, and I think that I was very encouraged, Yuka, as you discussed, a lot of the discovery of additional federal resources and your aggressive drive towards that. That is something to really be commended. So for our budgetary purposes, then, we're going to anticipate that we don't need to appropriate then any funds for that. Those will all be sought through alternative funding sources. This is probably, I hope it continues like this, because this is probably one of the easiest budget cycles I've been through so far in terms of the request, and it's definitely refreshing, and we hope that, and we pray that you realize all of these, resources coming forward. And once again, I can't help but commend your team for that approach, and of course, look forward to the continued progress, Lillian, as I know you've worked with the member that's been designated here to work on the efforts towards the new hospital and other endeavors. So we wish you continued support and luck with that as well. And with that, Mr. Chair, Sidus Masi, and thank you once again for your wonderful presentation.
Thank you, Senator Duenas. Senator Atta, do you have any comments or questions?
Thank you, Mr. Chair, and thank you to Team GMH. It truly has been a long 14 months from last year to today, and your team has really proven themselves time and again. And those awards are just honorable, really, to see how far you have gone over the months, and simple tokens of appreciation is always appreciated, right? But the true what do you call it, meaning of what you guys have done for the people of Guam is, no words could ever say thank you. There's just never enough words to say thank you for everyone, at the hospital. The only questions I probably have is, I noticed on your revenue projection and funding requirements for, and I think it's on page 4, the Department of Corrections, where you're saying you're $2.7 million, right? Requesting for $2.7 million for DOC, but yet they still have an outstanding balance of $5.6 million. So what is the MOU between GMH and DOC as for how you guys get paid, or when do you guys get paid?
It's the MOU is for us to run the clinic there. So we bill them every month for all the expenses, including the salaries of our personnel that are there, and then they reimburse us. And so our estimate is around $2.7 million for FY 2022. This does not include the amount that when the prisoners are brought to the hospital and actually admitted, that's a separate amount.
So that's a separate amount?
Yes.
So of the $5.6 million, what does this represent? Does this represent 1 year, 2 years, 6 months?
Prior year obligations, which
Prior
I understand.
obligations.
Right, they can't pay because it's prior year. But it's in our books that they owe us.
So the $5.6 million is from what year?
2018?
The 1.7 is for 2017 and 18. Mostly 2017, 2018 for the clinic operations. The 3.9 goes back to, I think, 2000, no, before maybe 2005 or something, yeah, for those patients that were admitted to the hospital. They did pay, DOA paid 2019. We had a memo from the Director of Administration, Mr. Byrne, and he said that he would pay for 2019 based on Medicare rates. So we did get something from the 2019 and a little bit of 2020, but not much after that.
Okay, I see. And then on the payer mix on page 6, you're showing a self-pay. The self-payers, I think, represents 14%, correct?
Yes.
And then on page, on the achieving financial stability, you're mentioning about engaging a self-pay task force to assist self-paying patients. Who is or what makes up this self-pay task force?
So it is the patient registration department working along with the social workers and case management department as well. We have a personnel, an eligibility specialist on our staff who actually processes the Medicaid and MIP, the public assistance applications. So prior to the task force getting more involved in it, they would just simply give the application, but the application it's pretty long. There's a lot of documentation you have to attach to it before you go take it to public health and get it processed. So now we're helping the patients with the social workers and the case management workers also. They're engaging and helping the patients to actually fill out the form. We have AmeriCorps volunteers that are also on site to help with the application process and also on the weekends so that those patients that are there on the weekends, they can still help them fill out that application.
So does this process happen upon a patient's admittance or when they first come in? And how do you determine that they're going to have problems paying, you know?
Because we cannot ask them when they're being admitted.
That's what I'm saying.
So no, we have to wait till they're actually in the hospital. And then the process is they run the list of the patients that have been admitted and what their financial classes are. So they pretty much just run a report of who's a self-pay and then go up to the room and visit them.
Okay, that's great. That's good to hear. So that at least they do have an alternative to assistance. They not be able to make payment. That's good to hear. I appreciate that. And the only other concern I had is with your comment when you mentioned about PPEs. You know that it was hard to come by and things like that. And then when they were available, you know the prices were just outrageously high. And I think that's a concern because we're still in a declared public health emergency, and perhaps maybe that's something that the Attorney General's office can look into if there's any price gouging on these PPEs that the hospital has purchased, you know? So, I mean, that's something that you may want to look into or inquire with the Attorney General's office, because if there is price gouging on the PPEs, then, you know, we need to hold these vendors' feet to the fire, because I don't think it's right, especially knowing that just 3 months ago, we were able to buy it for 14 cents a mask, and now we're paying $3.75 a mask. There's absolutely no reason for that. And on a declared public health emergency, you can't increase your prices. So there's something to look into, and, you know, every way that we can help GMH and, you know, ensure that you guys are being treated fairly and able to get your PPEs that you need without being price gouged, and, you know, that's what we got to look into. But thank you guys for everything you guys do. Like I said, there's not enough thank yous to go around, and we truly appreciate all that the staff and management and everyone up at GMH does for the people of Guam. Thank you again. Thank you, Mr. Chairman.
Thank you, Senator Tony. Senator Joanne Brown, do you have any questions or comments for the panel?
Thank you very much, Mr. Chairman. Certainly thank you to GMH. I know you were just here like last week. Thanks for coming back, and I certainly do appreciate the budget presentation and the breakdown that you provided. You know, it's amazing the things you can do in GMH when you have the money to do it, right? And certainly we know, and certainly to our administrator, having worked there for so many years, I know you over the years you've seen the challenges that GMH has had to go through, but being able to provide those resources, even though we've gone through such an unfortunate circumstance with COVID, at the other end of that, we're actually seeing where these financial benefits that are coming to the island, certainly to the hospital. You're certainly doing an awful lot of good work to take advantage of that opportunity in terms of the physical infrastructure, and yes, we know it's aging. I've had the opportunity, Mr. Kando, to go and tour and see the inner parts of the hospital that I otherwise would not have seen, and the challenges that GMH has gone through. And then on top of that, just the issue with regards to equipment, and it's good to see that you're able to also help facilitate getting new and updated equipment at the hospital. I do want to ask with regards to one key issue, and it's not part of your budget, but I'm sure we do want to know what the progress is on getting a chief medical examiner, because that's, I know there was a challenge probably in terms of the compensation package, but I think a lot of people are wanting to know where we're at with that, and is there any progress or hope that we will eventually get our own chief medical examiner, just in helping facilitate that whole process for our community when people pass away, and even more unfortunately, if they die from, unfortunate circumstance that might be crime-related and things of that nature.
Correct. Thank you for that question, but if I may just clarify, CME doesn't fall under GMH. It's
Okay, I know it's under the
separate
Attorney General's office,
organization.
but they're headquartered at the hospital, though, aren't they?
What was that?
They are at the hospital, though, aren't
They're
they?
using part of our hospital? Right,
I mean, the Morgan things are there. Do you
Right.
have, from your perspective, any updates on that, however?
Well, as part of the Postmortem Commission, I am a member representing the hospital. And so the Attorney General is the one that oversees that. And so they have a contract with the Hawaii CME, but because of the cost, they kind of limit only when they really need to have a forensic autopsy done.
Yes.
Because Dr. Dodderman, they also have a contract with Dr. Dodderman, who is a pathologist,
Yes.
and he lives in Saipan. So every 2 weeks, he comes to Guam, and he can do some of those autopsies, but they're not forensic autopsies. And he also does physical examination to determine if there's anything suspicious.
Yeah.
And so, he does that. Every 2 weeks, he comes to Guam.
But so far, no progress that we will have in getting one of our own.
They have tried to recruit, the AG, Attorney General's office, they have tried to recruit, and they've had some candidates, but unfortunately, it did not materialize. So they continue, it's an ongoing recruitment process.
Well, hopefully at some point we'll get that resolved. I think in most recent time, we've never been out of a chief medical examiner for this length of time.
True.
I mean, we remember Dr. Hee-Young Park. I grew up
Yes.
remembering the name of Dr.
I
Hee-Young
finally
Park
remember
and his
him.
reports,
He retired
right?
a long time ago.
Back in the day. With where you're at now, and I do appreciate the fact that you're not looking at asking more at this point for your budget from the general fund than you are. I think that says a lot, but certainly your efforts on working on collections and being able to assist individuals on self-pay, I think the combination of that more aggressive approach certainly can alleviate some of the financial challenges that the hospital has historically been through. How are you doing with regards to your collections from the insurance companies? I'm sure you'll continue to work on those relationships. How has that been so far? Because in the past, sometimes we've always heard those things that are contentious and confrontational and disagreements on billings and all that wonderful stuff. How are you progressing with them being able to pay back the hospital for the services that you've provided?
We have, as I mentioned, we have some issues with Take Care Insurance. We actually put them out of network last year for about 7 months. As a result of that action of putting them out of network, they did make a significant payment to us, but that was our request in order to engage them with this reconciliation. We actually signed a memorandum of agreement that they would hire a third-party firm to come and pretty much audit those outstanding claims. And so it's been slow. We didn't think it would take this long because it started since September, and so we're 7 months in already. So we've been kind of pushing them to hurry up and finish it so we can see what they owe, what we owe, so we can just clean that up. Because right now in the books they owe us $17 million.
Wow, that's a lot.
Yeah, it's a
Yes,
lot.
that could take care of this upcoming year.
Yes.
Throw in $1 million and you're all set.
They have been, in the past, I'll say month or two, they have actually been paying a lot more than they have in the past. So we think that that relationship is improving, but a big chunk of that really depends on this reconciliation because they want to make sure that they're not overpaying us.
Sure.
So that's why we really want to push that along. The other insurance companies have been pretty good. Different issues with the different companies. Aetna has really been very good with paying this past year. We've had some glitches in the beginning when they first signed on with Gov Guam, but this past year it's been a lot better. My follow-up supervisor meets with them every week. The other insurance company, she meets with them either every week or every other week just to follow up on all the claims that are all outstanding. So as long as we keep engaged with them,
Yeah.
it really works, yeah.
I wanted to ask you also, I mean, certainly with COVID and certainly your focus in taking care of the COVID patients this past year, I know impacted your services that you could provide for other types of care at the hospital. Where are you at now with regards to that for the public? I mean, because I'm sure there are people that probably would want to put off procedures or whatever, shy away a bit because of what we've been through. But that's also your customer base. So where are things now? Is it what percentage would you say you guys are back to operational status for people to be able to come up to the hospital for other types of procedures, alternate procedures and things that the hospital can provide at this stage with where we're at?
Yeah, I think our outpatient services are open now, but because we allocated so much space to the COVID rearrangements, we're just now going back to normal and closing those units and returning the units back to their normal locations. And so once we do that, our outpatient clinics are already open, but because they're limited in space, they're limited in hours. I think the operating room is back up and running. There's a backlog in the clinics because a lot of these patients have to go to their doctors first and then they get scheduled. So I think there's a backlog there. The other thing is, again, the confidence of the community. So I think as more and more people get vaccinated, then they feel safe to go to the doctor and get some of these things that might not be urgent, but certainly they need to get it taken care of. I think we're starting to see that pick up.
Well, good. I appreciate it. Again, thank you. I mean, what a year. I mean, this past year, and I hope we continue on this positive track and this year ends on a better note. But certainly as my colleagues and I mean, we can only say thank you. I mean, you've had some of the toughest jobs this past year in helping our people, including through the challenging times, because I don't think there's anyone sitting here that didn't know someone who passed away this past year, latter part of last year as a result of COVID. But you know, your efforts are appreciated. I mean, it's certainly helped get our community through some of the most challenging times collectively we've had in our lifetime. But continued success to you at GMH. I mean, it's a lot of work, but the dedication and the outcome is positive. It's good to see and hear that for a change. Thank you very much, Mr. Chairman.
Thank you, Senator Brown. Senator Tello, do you have any questions or comments for the panel?
Thank you, Mr. Chair, and good afternoon to everyone here. It's one of my favorite agencies. I know I've tried to advocate much for GMH, and I'm glad to see this task force is up and moving toward the direction of building a new hospital that we've tried so hard to do. I mean, if anything that we can take away from this pandemic is the fact that we really realize how important it is now. We need a new hospital. I mean, it's right in our face. And it's unfortunate that it took a pandemic like this to really show the urgency in doing so. But I greatly appreciate all the work you're doing in those efforts toward building the new hospital. So, and to the staff management of GMH, my heartfelt thank you. You know, Donkolu Sidus Masi for all the work you're doing. I realize the importance of having a good staff to make things work. And just by your presentation today and putting everything together, especially Mr. Kanto, I really appreciate the CIP projects that you were talking about earlier. So greatly appreciate. There is one thing, though, I have a question with Mr. Kanto since I have you. is the electrical health records that you spoke about. I don't know, you don't have page 13. The cost has already been appropriated for this, the funding for these, this electronic health records.
Yes, ma'am. This is being paid through. This is one of those projects where I spoke to Yuka very nicely, and so this is hospital funds. I mean, so this is over a 5-year period. The overall, so for the first 2 years of that 5-year period, the monthly is about 109,000, almost 110,000, and then for years 3 through 5, it'll be about 85 to 90,000 per month.
Okay.
So the total 5-year cost is about $3.72 million.
Okay, thank you for that. Just get an update. I really appreciate that. Also, Yuka, since with regards to achieving financial stability that you talked about, there's an area at the bottom where strengthening relationship with insurance companies that my good friend Senator Brown mentioned earlier. In that section here, is there any companies that you are being contract with, kind of like collection agencies that you might be working with currently right now to try and retrieve those costs?
We are not contracted with any collection agencies. We do have a collection department that makes a lot of the calls to the patients. And then we also, what's helped us a lot is having the Attorney General's office work with us on the problematic accounts. They seem to have more authority, I suppose, so they actually will call the patients and tell them that they may be summoned to court and what have you, and then all of a sudden they're making payments again. So it seems to be more effective. I've been told that the collection agency arrangements of the past didn't work out very well, so those contracts did end, and we're trying to just work with the AG's office, which has been a good thing, yeah.
Do you have a designated attorney that's been assigned to the hospital?
There is a group of them in the solicitors division that the business office manager at GMH works directly with them.
Okay, thank you so much. And Mr. Cano, I noticed in the printout here with regards to the itemized statement, itemized utilities, there is the boiler fuel that I know it's a little bit less than what you requested in 2021. Is there a reason why it's gone down in price? I mean, we see gas going up all the time or fuel going up all the time. I just noticed that it's a little bit shorter than last year's request.
It's possible that there may have been a percentage decrease in the overall budget. I don't know, but typically the surcharges for fuel is tending towards the upward trend. So if we run into any shortage, I mean, we don't have any problem working with Yuka to do a budget modification. I'm not too worried about that.
Okay, so there's
Actually, that amount has been reduced very little, slightly, but based on the usage of the past year. So if we see it kind of trending down, then I'm not afraid to cut it.
Okay, I just noticed that when I thought it was kind of odd considering the situation. Also, when you mentioned about collections, when we were talking about collections, DOC owing GMH $5.6 million. Has DOC done anything right now to pay down this debt? Is there a payment plan they're doing or anything like that? Because they're going to be sitting in front of us pretty soon, and we're going to be asking them if they put aside some of that funding.
No, there hasn't. The only movement we've seen on that 3.9 that they owe us for the inpatient inmates that come in and are admitted to the hospital, there was a payment made for 2019 from DOA, and like I mentioned, the DOA director sent us a memo and said that he would arrange to pay for that based on Medicare rates. So those gross billings were adjusted to the Medicare rate, and so we were able to collect on most of the 2019 inpatient receivables.
I know that you're probably the first one knocking on the door for that ARP money that's coming out, and especially when it comes to capital improvement. So hopefully we can, divert some of that money toward the Guam Memorial Hospital and the new hospital. I mean, we currently need to keep our current hospital up and running and safe for all the employees, all the great employees you have at Guam Memorial Hospital. Sticking with trying to retrieve some of these payments to Guam Memorial Hospital, what information, if any, does GMH have on the restoration of the Medicaid eligibility of COPA residents? There's an article that came out that Congress is allowing now, the recovery from Medicaid from COPA, the compact impact individuals right now. So what are you doing to try and, retrieve some of that funding through Medicaid?
Conversation with Mr. Art, San Agustin, is that, yes, they have been approved, they're eligible, but I don't think they've got some processes and procedures in place yet to get that reimbursement, to the hospital for citizens, for the COFA citizens.
Yeah.
But they haven't yet moved forward towards that, the process. But yeah, we understand, and we received communication that those citizens are now deemed eligible for the Medicaid.
So maybe, yeah, go ahead.
So like I mentioned, we have the eligibility specialist on our staff. It will give the application to everybody that is a self-pay. We wouldn't not give it to them just because they were possibly a group that would not be eligible. We'll let that process go through itself, actually submitting the application for public health to determine whether or not that individual would be qualified for Medicaid or MIP.
Okay. And what is the percentage of patients that are from COFA that are at Guam Memorial Hospital that?
I just don't remember the exact numbers, but there have been, we keep track of the COFA citizens.
Right, and yeah, I'm curious to see here, and also what that price tag has been so far with Guam Memorial Hospital.
Right.
I think it's very, yeah, I think it's very important as we move forward to look for funding, any kind of federal grant, or continuing to push, the U.S. for, this unfunded, underfunded mandate that we have on Guam.
Sure.
So thank you so much, and thank you, Mr. Chair, for the opportunity, and God bless you guys for everything you're doing, and I wish you the very best. Please be safe.
Thank you, Senator Tuttle. Senator Mary Torres, do you have any questions, ma'am, or comments for the panel?
Yes, thank you, Mr. Chair. I have a little of both. First of all, congratulations on your great success in the capital improvement projects. It is incredible how much work you've done, and it's reassuring to know that the hospital is being shored up so that it can have greater life, at least until we can figure out the replacement with a new hospital. But kudos to your team. I just want to ask briefly about the payer mix, because the payer mix has always been the one main reason cited for the hospital being crippled, its inability to generate enough monies to sustain its operations. And you noted, Yuka, that the 3 M's make up 50% of the chart of the proceeds that come in from the payer mix. I also noted that I noticed that in your decision package, in nearly every division, the top line items is, number one, is improving cash flow in most of the division items. I wanted to ask you, about the payer mix, and specifically on number 2, which is you improve cash flow by addressing 7 distinct issues, and one of them is continuing efforts to obtain underpayment reimbursements for Medicare services through annual adjustment and permanent rebasing requests with the Centers for Medicare and Medicaid Services. I want to ask you, what has changed in the last year or two that has made the percentage of the 3 M's not so detrimental to the hospital? And what are the ongoing efforts with regard to the Medicaid caps and getting further reimbursement or changing or upping the rates of reimbursement? Can you discuss that a little bit more?
Yes, because our Medicare reimbursement is based on a per diem and a cap on per discharge, we had the rebasing done that put us back to FY 2014 expense rates, right? So we are right now at FY 2021, so we're 7 years behind. So what we are starting to do is work with a Medicare consultant on where we can move forward, and it's possibly time to put together another case for a rebasing. And that is an extensive process, but it needs to be done in order for us to get caught up to the actual expenses of what it takes to take care of a patient based, they're just paying us per discharge. So like, if a patient stays for more than so many days and they've already exceeded that cap, we're only going to get paid for that amount. So we need to renegotiate and revisit that rebasing case again.
But the rebasing, though, did occur recently, right? That allowed you to get a lot more money than you were getting previously? Because I notice you're a lot more healthy. That isn't the discussion point in the budget hearings anymore.
Because it was recently updated, but it only updated to FY 2014. So it's taking FY 14 costs, where we're right now 7 years later at FY 21 costs. So, and the costs nowadays can be very different because of how we're reacting to COVID and what we need to do to be prepared for anything going forward, like maintaining all the CIP we're doing. We're going to need to maintain all of that, hiring, making sure that our staffing levels are really at par, because we can't be caught off guard in case this happens again.
I see. Okay, so I understand you made progress, but it was only up to a point that it's still 7 years behind.
Yes.
Okay, I get it.
Still behind.
I wanted to ask Dr. Berdallo, I'm not so sure what you mean by changing the care model from primarily inpatient hospital-based to outpatient hospital-based. What does that mean, and how does that affect the revenue? Is that elective surgeries, or what exactly is that? Inpatient to outpatient models? Or Mrs. Posadas?
I'm sorry, you're referencing the...
I was referencing the objectives that is in the summary discussion of the...
Yeah, so the reimbursement rates for inpatient stays for the 3 M's are per diem. And again, as Yuka just stated, the per diem rate is based on the cost, or it's set at the 2014 level. Outpatient services are reimbursed on an 80-20 based on the Medicare current rates. So whatever the Medicare publishes its outpatient rates, I think we get them every January. I think we don't get them into the system till March, but every fiscal year Medicare applies an adjustment, and those rates are published. So the outpatient services are based on current rates, and they're not per diem, they're fee for service. So if we do a lot more outpatient services, our revenue generating ability is a little bit higher. But we have to balance that with what services are being provided out in the community, because we have to take care of inpatients, but again, it's a balance between who can do, how big do we want to get?
Yeah, because your costs for the same treatment would be a lot higher, right, in the hospital setting versus in a clinical setting, or that's part of the issue, what can be addressed on a public health or clinic level versus them appearing at the hospital.
Yeah, and it's where they're performed, because certain outpatient services should be performed in the hospital. So if you're having a cardiac catheterization, there aren't that many places that do that as an outpatient. I think pulmonary patients who can decompensate during certain kinds of tests. Sometimes you like them to be near an acute care facility. So, but generally, right, we wouldn't be doing OBGYN pap smears in a hospital setting. It would be much more cost effective to do them at a clinic. But I think we do want to convert and do a lot of our procedures in the outpatient setting. It's just more efficient. We can schedule them and we get reimbursed at a higher rate, or a more current rate, maybe is a better way to say that too.
Yes. I just was wondering, are we getting pretty much close to normal where elective surgeries are on the upswing, or because I know that that's a great majority of your fees as well, right? The elective surgeries?
You know, I think, again, there's a backlog, there's a hesitancy of patients to actually go to their doctor and say, okay, I'm ready for my surgery because I don't want to go to the hospital because there's COVID there. So I think there's a combination of, as people get more vaccinated, now they're feeling more ready to go back to the doctor, but at the same time, when you call the doctor's office, yeah, they're full already because all these people are coming at the same time. So now you have to wait for 3 months to get an appointment. But from the hospital standpoint, we're moving to normalize those operations. So we are going back to normal operations. So our operating room is open. We are performing those. Our outpatient services are now up and running. We're just, again, reallocating space back to normal because we took a lot of space for the COVID response. And as much as we all want to be back to normal, really we see the numbers, right? So when you see 10 more people test positive, from the hospital perspective, we're like, okay, wait, should we really just trust that we're not going to get a surge? So I think we are not 100% back to normal, but we're pretty close. I would say, about 90%, or because we're hedging a little bit because Easter was there and people are out and about, and we don't want to convert and then have to go back to pushing people back into the closet, which some of our wards went into the closet because we had to use their space.
Thank you, Ed. And I'm going to continue to work hard on getting the nurse pay adjustment. I know that there's progress on that and a commitment from the governor to help fund the nurse pay increases. So we'll just work. And thank you for also always being readily available for testimony and advice as well.
Yeah, staffing's always an issue, and I think it's been an issue for a lot longer than before COVID, and it'll probably remain an issue for quite a long time. We live in a fairly remote place, and getting people to move out here and trying to attract staff, also growing our own, and as our population grows, we have to make sure that the university programs grow along with them. So, but if we're graduating the same numbers, but our population is growing, we're always going to have to recruit from off island, and getting people to move here is, all those videos of the nice beach help a lot too, and a better salary for sure helps.
Right, right. Specialty nurses are in demand worldwide, but thank you very much. I appreciate your answers.
Thank you, Senator Torres. Senator Guåhan, do you have any questions or comments for the panel?
Thank you, Mr. Chairman. Thank you to the panel. It's a wonderful slide presentation. It was very explanatory. Just a few questions. When I'm looking at the gross revenue and patient census, well, first, congratulations that we increased our collections based on billings because we had the time during COVID to really study this. From 91 that was billed, and our collections are close to 50, which is a better percentage than we've had before. I like how that goes into how you plan to achieve your financial stability by hiring the revenue cycle management consulting person. And I suppose that's where he'll really help with the modernization and structure to increase our collections even further. I think that's a great idea to achieve that financial stability. And just as a segue, I'm thinking maybe DRT can use somebody like this as well, so we can increase our collections. That's the main object that we really must do to increase our collections. On your achieving financial stability slide also, you mentioned working with DRT and collecting from the tax refunds, $3.5 million. I'm supposing on the payer mix slide, would I be correct, that will be under the self-pay that you're getting the tax refunds garnishing from, right? But then again, on your financial stability side, you have a plan of action for that with the self-pay task force to assist them in completing these applications. So another great plan. So congratulations on that as well. I suppose with again, the revenue cycle management consultant, and this is one person, is this a team?
It's a firm. It's a company, yeah. So they have a team.
Oh, it's a team. Oh, okay. Then they can help us really focus in on, with the collection, so we can pay our accounts payable, right? That's the object, because we're in the red 17 million, right?
Yeah.
So is that the goal? I mean, this is achievable with what the revenue cycle management consultant team is coming out to do, right? This is something that can be achieved with us contracting this team.
That's the goal, yes. We have quite a few, if you look at the receivables from all of our payers, from the insurance companies, there's a lot of money just sitting there that's not collected due to denials, mainly denials with the insurance company. So when we bill them, they come back with a denial saying we can't pay it because we probably didn't bill it correctly, or that it's not supported with some kind of documentation, or there are many other reasons. So in order to get a clean claim out, we really need to make sure that that bill is thoroughly scrubbed, the codes are all correct, the documentation is adequate, so that when the claim does reach the insurance company, they have no choice but to pay it. They have to pay it within 45 days. So that's the cycle that we want to make more efficient, instead of waiting for a denial, having to deal with the denial, and sometimes it can drag out for 6 months to a year before we get paid, sometimes even longer.
Okay, I see. So that's the goal with this team,
yes.
And we're, of course, then that gets into your current financial posture, where you're talking about the allowance that based on the receivables, right? And this is something that we want to iron out with through the help of the Revenue Cycle Management Service team, so we can reduce that amount of the allowance, right? It's quite large in what we're doing.
Yes.
So we're really going to hone in on what GMH is actually billing, whether it be self-pay or to whoever else has to be billed. So there'll be no disputes.
Yes.
Right now we have errors here and there.
We have a lot of, yes.
And then there's an agreement, okay, let's just decide and which is the allowable.
And denials are really, it's almost like a waste of time. It takes so much resources from the billing and the follow-up staff to deal with all the denials, one denial. I mean, we have a denial management team, a very small team to deal with all the denials. So it just takes so much work and effort to deal with a denial, whereas if we had a clean claim, we just get paid and it's over and done with. Yeah.
And nobody's going to question double payment. You charged me twice here on that. No, okay, I understand. I'm wondering, because it's really looking good here, are you looking at any other consultants for GMH to consider? Are there other projects other than on the financial side? Or is there, I mean, your capital infrastructure improvements are there. Are you looking for a consultant to assist you there? It seems like you're going quite well on that side. Are you looking at bringing in other consultants to assist GMH? No? Okay. Okay. Moving then to the capital infrastructure update. I'm glad to hear, especially on the elevators there, 1 and 2, that was recently completed, so that's good news. And now is there also 3 and 4 on elevators?
Yes, Senator. So these are These are not new elevators. We're upgrading them, modernizing them, replacing cables, replacing cabs, things of that nature. So they're not entirely brand new, but after we're done with it, it's performing like they're fairly new. We're extending we've got a new life because we cannot operate without operational elevators.
Right, that's the original since we were there, right? So, but now we're moving to change that say no longer an operation to it's an operation. I don't have to use the doctor's elevator anymore. I can actually use the guest and visitors.
Yes.
Oh,
Yes.
okay.
When you come into the elevator lobby, we want you to be impressed with the nice shiny floors. We don't want you to be seeing those chains.
Thank you for that, and congratulations on the progress and those that you have in the pipeline. As you mentioned, we have another 5 to 7 years that we may be at this current facility, and we're going to make it as usable and clean as possible. So it's a lot of hard work to your team. I do appreciate that. And then finally, on the planning and development on the alternate care facility at SNF. So if I envision this correctly, right? Our COVID is under control, for example, right? Let's use that as an example. Then all of a sudden, this other strand comes through. What we're going to do with the SNF, because it's through this 100% federal funded awarded, this is where the 44 or 50 some rooms are going to be if we have something similar to COVID or another COVID strand to come through. So we can maintain GMH for its outpatient treatment, so we can continue on with the revenue needed to sustain GMH and their sustainability in the meantime. So I think that's a really outstanding plan. And just finally, though, when you have professional support here, is that where on your budget, is that where your revenue consultant is being paid through, the professional support here? Is that the funding?
Sorry. The professional support services, those are your allied health professions like pharmacists, dietary, respiratory therapists, radiology, the lab. Those fall under the professional support services.
Oh, okay. So the revenue contract consulting is being paid from where?
The which one? The revenue cycle management consultant?
Yes.
That's going to be coming out of our operational.
Your operational
right.
costs. Okay. Okay, well, I thank you, and also want to congratulate you as well for your awards for the 2 healthcare awards of the Asia Awards there. So congratulations. Obviously, it shows on your report and the information you provided us. I would have given you a reward too. So thank you very much. Thank you to your team. Thank you, Mr. Chairman.
Thank you, Senator Moylan. Madam Speaker, you had a few questions. You want to do a follow-up?
Yes.
And then I'll close.
Thank you, Mr. Chair. So on the overall Government of Guam FY22 budget request from the executive, they recognize a reduction in revenues of $30 million, less than the FY21 overall revenues. So that $31 million reduction is made up of about $10.5 million from GMH operational funds, so we're not funding any of that this year as we funded last year. And again, there's 0 requests for CIP from the GMH. And then there's a reduction of $17 million from the Department of Public Health. So 27.5 approximately of that 30 million reduction in revenue is coming from the hospital and public health. That's the shift in this FY22 budget request that we received. And I just wanted to check the director, if you could just confirm, so the board approves that GMH is making 0 requests for CIP for FY22.
That is correct, Senator, Speaker. And even the previous budget, we did not include CIP. We put it in the book, the budget book, but we did not factor that into the budget, actual budget requests.
Right, no requests. And Yuka, were you able to take a look at this OFB chart that we were provided? So on the top of the chart under subsection A, total operations, there's a 140. That mirrors the number that you provided us on your PowerPoint, 140 for operations. But then this part, total capital, subsection B, is 11 million. Could you just explain what that 11 million is?
The 11 million is the insert of the CIP listing that it's just the insert into the budget. But it was not added to the 140.
Okay, so where does this come from, I guess? This is just an OFB insert, not a GMH? Okay. I guess that's why I want to make sure this is not a GMH request. This is something OFB.
No, ma'am.
Put in? Okay, and then, so just some other minor questions. Recently, they eliminated a doctor's logging in as on call while doctors are on staff. Is there a savings expected from that change?
I'm sorry, can you repeat that?
I don't know, I'm not sure if we got this from the minutes of the board meetings. There's a recent change in policy that they tried to eliminate doctors logging in as on call while there were already doctors on staff. And I'm just asking if there's a savings expected from that or not, or something significant or not really? If you're not familiar, then I'll follow up. I'll just do that. We'll follow up with that later. What about for the AG's assistants? Do you pay them? Do you pay the AG's office? All right.
No, we do not.
I know. This started several years ago. I remember talking with them when they were going to do that. They kind of did that willingly, so I just wanted to make sure that's still the case. Are you also contracting a private attorney? You don't have a private attorney?
Not
Okay.
right now, no.
All right. And then the FMAP that you use to calculate your 140, you're expecting to use the same 89%, I think, that you used this year. What if that doesn't happen again next year? Do you have the estimated difference that it might?
Not an estimated difference right now, but if the FMAP is going to go back to the 55%, then we will anticipate not getting any payments from public health for the Medicaid and for the Medicaid patients. I mean, at the level that we're getting right now. Right now, they're paying very quickly.
Right.
Yeah.
That's what I'm asking. But you must have an estimate of like a backup plan in case that happens.
The 140 million really is what we need. We have to either prioritize a lot very quickly to face those shortages, but we really can't go much lower than that. I mean, we have a staff to support.
Yes.
We have to stay open. We can't even close, not even for an hour. We are 24/7,
Right.
365 days, and we have to be open to provide that care to all the patients that come through the doors.
Well, that's why I'm concerned in case that happens. I'm hoping, we're all optimistic that's not going to change this year. It will remain permanent, hopefully. But just in case, I just wanted to know what would we need to offset that with, right? But
We would still bill public health for the Medicaid. It's a matter of how they're going to pay us.
Okay.
Yeah, it would be an issue.
All right, and then this is only $1 million, but there was a $1 million request from GMH to the Cancer Trust Fund. And I think it was awarded and then rescinded, the one that's managed right now at the UOG, the Cancer Trust Fund. That was supposed to be for $500,000 for a C-arm imaging scanner, $360,000 for a lab info system, $25,000 medications for cancer control, $75,000 for an oncologist partnership, $20,000 for patient education materials, $20,000 for inflationary costs. Just this $1 million. Have you now budgeted for that? Would that be taken care of with the 140 You'll be able to take care of the cancer patients?
Senator, we were given a much lower award than that. That was our application.
Oh.
What they awarded was about, I think it was about 110,000.
Oh, that's very small.
So it's a much smaller amount. A portion of that is for an oncologist, and then pharmaceuticals, the chemotherapy, pharmaceuticals, training, things of that nature. So we're waiting for an official award from UOG, but we will be implementing that grant.
Say that again?
We will be implementing it. We don't have an official award from them, so we've been in communications with UOG to get that official award.
Oh.
So that we can have that, it's like a notice to proceed.
Okay. Well, my information is that they rescinded it, so I guess, are you able to cover the cancer services is what I'm asking? Have you budgeted for that as well? The 1 million that you had asked UOG for?
I know the C-arm is where we moved that funding to the CARES money that we have, because the C-arm was estimated to be around $400,000, I believe.
Yeah.
So we moved that funding to the provider relief fund. So that's part of one of our equipment that we will purchase.
And we actually were able to purchase 2 C-arms. So we are getting the C-arm for radiology, interventional radiology, and then the other one is for the OR. So we find other ways, other funding sources to do these. If we feel they're pretty important. So we proceed one way or the other.
Okay, well, that's great news that you're taking care of that. I was just worried because it was for cancer patients. But then finally, have you submitted a request for ARP funds? Can we get a copy of that, please, if you have?
Sure. We submitted a letter about, 2 weeks or 3 weeks ago. We requested for 12 million, 10 of that to cover for the loss revenue, and then 2 we're going to use for the Z-Wing.
Capital improvement, Z-Wing?
Yes.
All right. Lost revenue, can you just explain that?
The lost revenue in the audit that the OPA completed, they recognized that because we suspended, elective surgeries, our census went down, and outpatient services we suspended, we lost revenues of about $10 million.
All right. Okay, thank you very much. Thank you, Mr. Chair. Thank you again to all of you at GMH.
All right, thank you. Thank you, Madam Speaker. Ms. Posadas, you identified there are some agency owe you guys money. Okay.
Yes.
I will commit that our office will look into that, and we find a way to get that thing settled.
Thank you.
Because that will just keep you going. You don't need no bill. We don't need no so-called deficiency or lapse money. We'll just find it, identify it, and tell the agency that we're going to do adjustments, or we'll figure out how we need to do it. Because I believe our colleagues want to make sure that GMH stays on its feet. Like the last budget hearing we had, somebody was on steroids. I'm not going to say anything about GMH because you guys got all the drugs. You got the pharmacy, so may God bless you. Continue to do what you're doing, and we'll figure out a way. And we will be in communication with your office, and we see what we need to do. I know that the OFB folks are probably saying, oh, Lord, he's opening up the door. Yes, GMH needs to be helped. No different than any other agency. But everybody's going to need GMH. If not today, tomorrow, or next week, somebody's going to need GMH. And as long as you're ready, we got to make sure. Your CIP guy, he's on ball. He's on the road. And your comptroller's making sure the insurance people are not in denial. Pay the bill, and have a nice day. Take care. The committee will continue to receive testimony. Please address your written testimony to the Committee on General Government Operation, Appropriation, and Housing, and submit it via email to Senator Joe S. Agustin at gmail.com, or to my office located at Rand Care Building, 2nd floor, Suite 3, 761 South Marine Corps Drive, Timoning, Guam. Jesus Masi for your attendance and participating in today's hearing, ma'am, and your folks. And for those at home, thank you for watching. The budget hearing on Bill 55-36 COR relative to the Guam Memorial Hospital Authority is now adjourned. It is now 4:12. Please drive safe, be safe, and take care.